what is difficult to treat myeloma? And I think the way I conceptualize it is, we always talk about high risk. What is high risk? Genetically high risk. But one of the bigger topics that we like to refer to is functional high risk. If you already get a standard therapy and the average remission is 1 year or 2 years and you get 6 months, it doesn't matter what your genetics are, you're functionally high risk. If you're refractory to an IMiD, a PI, and a CD38 monoclonal, doesn't matter what your genetics are, you're functionally high risk because we have fewer options. So how do we attack these patients when we don't have a clinical trial ready to throw them on? So really embracing other mechanisms of action are key. So right now in the US, we have options of BCMA targets like Blenrep, signs like Selinexor. Unfortunately, we no longer at the moment have opportunities for panobinostat and melflufen, but those drugs were frequently utilized in that realm as well. The other area that I think is really key is finding out additional genomic information in this patient group. Because everyone talks about venetoclax and 1114, but it turns out there are far more actionable mutations in myeloma than we realize at first glance. So there are all these different next-gen sequencing platforms, but if you have a patient who's multiply refractory, consider sending one of these to look for things like RAS mutations, RAF mutations, FGFR3, CDK. So the reality is there are drugs in other diseases that you can port over to myeloma when you need it. Not quite ready to put somebody on a BRAF inhibitor front line, but if you've had some of the classics, this may be the next go-to if you can't get them on a T-cell redirection therapy or a clinical trial.